Welcome to the Hospital Medicine Unplugged podcast.
Thanks for joining us. Today, we're diving deep into a really fundamental topic, something that touches almost every patient population we see in the hospital: the evidence-based management of enteral nutrition, or EN.
Right. And our goal here isn't just a quick overview. We're aiming to give you the most current practical strategies based on the major guidelines, ACG, ACEPIN, and some key reviews like the ones in the New England Journal.
Exactly. We want this to be about clinical efficiency, about patient safety, making sure our tube feeding decisions are really grounded in the best available data.
And it matters hugely, doesn't it? Because malnutrition isn't some niche issue. It's incredibly common in hospitalized patients, especially our critically ill ones.
It is, and it's directly tied to worse outcomes. We see more complications, higher infection rates, longer times on the ventilator, increased mortality, and of course, longer stays and higher costs. It's a major driver.
When someone gets acutely ill, their body goes into this hypercatabolic state, right? Driven by inflammation.
And if we don't provide nutritional support, they just can't recover effectively. That's why EN, enteral nutrition, is really the preferred way to go over parenteral nutrition, PN.
Because it keeps the gut working.
Precisely. It helps maintain gut barrier function, seems to reduce infection risk, and you avoid all the issues that come with central lines and large glucose loads from PN.
Which brings us to maybe the biggest shift in practice recently: the timing. When do we actually start feeding?
That's probably the most impactful piece. The evidence is really robust now. Starting EN early in those high-risk patients makes a significant difference. Fewer complications, shorter stays.
So the guidelines aren't just suggesting it, they're basically mandating it.
Pretty much. Getting the timing right is crucial. But before we nail down the when, we need to be clear on who actually needs EN and how we deliver it.
Okay, let's start there. Delivery basics. EN means putting nutrients directly into the GI tract through a tube.
Right. And the type of tube really depends on how long we think the patient will need it.
So short term is what? Nasogastric?
Yeah, nasogastric or maybe nasoenteric if we need to get past the stomach. We're talking, up to maybe 4, potentially 6 weeks maximum.
But if it looks like they'll need support longer than that,
then you got to think about percutaneous access. A PEG tube, percutaneous endoscopic gastrostomy, or maybe a PEJ, into the jejunum. It's safer and much more comfortable for long-term use than having a tube in the nose.
Makes sense. Okay, so who are the candidates? Who needs this?
Broadly, it's any adult patient who can't eat enough by mouth to meet their needs and who is either already malnourished or considered at high nutritional risk.
And that covers a lot of ground.
It really does. People immediately think ICU, critical illness, and that's definitely a big group. But you also have patients with swallowing problems after a stroke, for example.
Right, dysphagia.
Or neurodegenerative diseases, ALS, advanced Parkinson's, dementia where intake becomes inadequate, certain GI diseases like Crohn's or severe liver disease, and definitely some cancer patients.
Oncology is a big one, especially head and neck or esophageal cancers where swallowing is physically difficult.
Exactly. The guidelines are pretty specific there. If a cancer patient can't take anything orally, or they're only managing, say, less than 60 or 75% of their goal intake, or if they're already moderately or severely malnourished, EN should be strongly considered. It can really impact their ability to tolerate treatment.
So it's not just about do they look thin. We need objective criteria.
Absolutely critical.
Yep.
You can't just eyeball it. The guidelines emphasize using validated tools. Things like the GLM criteria, the Global Leadership Initiative on Malnutrition.
GMM, how does that work?
It's a two-step process, essentially. It combines phenotypic criteria like weight loss, low BMI, reduced muscle mass, with etiologic criteria, meaning the cause, like reduced food intake or inflammation from disease.
So it captures both the physical signs and the underlying reason.
Right. And ACEPIN, the American Society for Parenteral and Enteral Nutrition, also has its own well-validated criteria. Using these tools helps standardize the diagnosis and ensures we're intervening appropriately.
Is there anyone we don't feed, even if they're not eating much?
Yes, and that's an important point too. If you have a patient who was previously well-nourished, is considered low nutritional risk, and you fully expect them to be eating normally again within, say, 5 to 7 days.
Like maybe post-op uncomplicated appendectomy or something?
Potentially, yes. In those cases, EN usually isn't needed. You monitor them, support them with IV fluids if necessary, but you don't necessarily need to place a feeding tube right away.
Okay. Now, the definite no-go zones, the absolute contraindications. When is EN simply unsafe or futile?
There's a pretty clear list. Mechanical bowel obstruction is one. prolonged ileus, where the gut just isn't moving.
Obviously.
Known severe gut ischemia. You absolutely cannot feed an ischemic bowel. Uncontrolled peritonitis, high-output fistulas where anything you put in just comes right back out before it could be absorbed.
Right, like an intercutaneous fistula pouring out liters.
Exactly. And severe active GI bleeding. You need to control the bleeding first. And critically, severe shock or profound hemodynamic instability.
That last one, hemodynamic instability, that feels like where the practice has shifted a bit, doesn't it? It used to be any pressors meant no feeding.
That's a key area of evolution. The absolute contraindication is uncompensated shock. The patient requiring escalating pressor doses, showing signs of poor perfusion like rising lactate, worsening acidosis. In that state, the gut is likely hypoperfused, and feeding is dangerous risk of non-occlusive bowel ischemia.
But what if they're stable on pressors?
If the patient is hemodynamically stable on low to moderate stable doses of vasopressors, and their perfusion seems adequate lactate clearing, good urine output, then the guidelines actually support cautious initiation of trophic feeds.
Trophic meaning?
Meaning very low volume, like 10-20 million mL per hour. The goal isn't really calories at that point. It's more about providing minimal stimulation to the gut lining, the enterocytes, to help maintain mucosal integrity. But it requires very close monitoring for any signs of intolerance or ischemia. It's a careful balance.
Got it. So assuming no contraindications, we've identified the patient. Now, the timing, that early EN mandate.
Right. The big principle. Start EN as soon as it's feasible, unless there's a reason not to. And always prefer EN over PN if the gut works.
And in the ICU, what does early mean?
For critically ill, high-risk patients, the major societies like ACE-PEN and SCCM are clear. Start EN within 24 to 48 hours of their ICU admission.
That's a tight window, 24 to 48 hours.
It is. And the data backing this up is really quite strong. Multiple studies, meta-analyses show that starting EN early compared to delaying it or starting PN early leads to fewer infections, especially VAP.
Ventilator-associated pneumonia.
Right, shorter duration of mechanical ventilation, shorter ICU and hospital stays, and potentially lower mortality. It seems preserving that gut function early on is key, preventing bacterial translocation, supporting the microbiome.
Okay, so start early, but there's a catch with the dosing, right? Especially in that initial phase.
Huge catch. And this is where people sometimes get tripped up. Early EN in the critically ill does not mean pushing immediately to full caloric goals. That's actually contraindicated in the very acute phase.
So you start early, but you start slow, low volume.
Exactly. You start with restrictive or trophic feeding. The idea is to intentionally underfeed in terms of calories for the first few days, maybe up to day 4 to day 7 of critical illness.
Why deliberately underfeed? That seems counterintuitive.
Because in that acute phase, the body is in such a state of flux inflammation, metabolic stress. Pushing full calories too early can actually cause harm. It can lead to hyperglycemia, electrolyte shifts, increased CO2 production, and potentially worsen gut ischemia or intolerance if the gut isn't ready.
Okay, so what's the target then initially?
We typically start very low, maybe 10 to 20 millimoles per hour. The goal is something like 12 to 25 kilocalories per kilogram per day. The guidelines explicitly say not to exceed about 70% of the calculated energy goal during those first 3 days. It's more about supporting the gut than replacing total energy expenditure right away.
That restrictive approach is specifically for the critically ill, though.
Yes, absolutely. That's for the acute phase of critical illness.
If we're talking about a non-critically ill patient on the medical floor, say, someone admitted with pneumonia, maybe a bit malnourished, can't eat enough.
For those patients, the timing is similar. Try to initiate within 48 hours if they can't meet needs orally, but the advancement is different.
Faster.
Much faster, generally. If they tolerate the feeding, you typically aim to advance their goal rate within 48 to 72 hours. You only go slower, maybe over 5 to 7 days, if they're showing signs of intolerance like nausea, vomiting, significant distension. Their system isn't under the same level of acute stress as an ICU patient.
Makes sense. And surgery, post-op patients. Historically, they were kept NPO for ages.
Yeah, that fear of the anastomosis kept people NPO for far too long. Modern evidence, especially with ERAS protocols, enhanced recovery after surgery has completely flipped that.
So even sooner for them.
Often, yes. The recommendation is to provide EN within 24 hours after surgery, whenever feasible, especially if they were poorly nourished before surgery or if it looks like they won't be eating adequately for more than a week after surgery. Early feeding helps wound healing, reduces infections.
Okay, so timing is critical. Let's talk about the actual mechanics. How do we deliver it? Continuous seems standard in the ICU.
Right. Pump-assisted continuous infusion is generally preferred for critically ill patients. It minimizes the risk of large volumes hitting the stomach or small bowel at once, which theoretically reduces aspiration risk and intolerance.
What about bolus feeds, like giving a larger amount every few hours?
You see that more in stable patients, maybe someone going home on tube feeds or on the floor if they're awake and alert. It can allow for more mobility off the pump. But in the ICU setting, continuous is usually the default for safety and tolerance.
You mentioned something important earlier, volume-based feeding protocols. Tell us more about that.
Yes, VBF. This is a really important strategy to actually meet the nutritional goals we set.
Because feeds get interrupted all the time.
Constantly. Patient goes for a CT scan, needs oral meds, has a procedure, tube gets clogged. All these little interruptions add up, and with a fixed hourly rate, the patient ends up getting way fewer calories than prescribed over 24 hours.
So volume-based feeding tries to compensate.
Exactly. Instead of just setting an hourly rate, you set a total volume goal for 24 hours. The protocols, often nurse-driven, allow the nurse to adjust the hourly rate upwards within safe limits for a period of time to make up for volume missed during interruptions.
How does that work practically? Won't just cranking up the rate cause problems?
It's done carefully. For example, if feeds were held for an hour, the protocol might allow the nurse to increase the rate by, say, 25% for the next few hours to catch up. There's always a maximum rate allowed to prevent overwhelming the gut. But studies show VBF significantly improves the percentage of goal calories and protein actually delivered compared to standard rate-based feeding.
Seems like a smarter way to manage the realities of hospital care.
It really is. And alongside that, basic safety measures are non-negotiable. Head of bed elevated 30 to 45 degrees. Using prokinetics like metoclopramide or erythromycin if there's evidence of poor motility.
And the connectors?
Absolutely crucial. Using ENFit connectors everywhere. These are designed so they physically cannot be connected to IV lines, preventing potentially fatal misconnection errors.
Yeah.
That needs to be a hospital-wide standard.
Okay. Another decision point. Stomach versus small bowel. Gastric versus postpyloric feeding. When do we need to bypass the stomach?
Gastric access, NG or PEG, is the default. It's easier to place and manage.
Yeah.
But you move to postpyloric access, placing the tube tip in the duodenum or jejunum, ND or NJ tube or a PJ, in specific situations.
What?
If the patient has known impaired gastric emptying, like diabetic gastroparesis, or if they have persistent vomiting or really high gastric residuals despite prokinetics. Also, if they have a documented high risk of aspiration that isn't managed by head elevation and prokinetics alone.
Is it better?
For those specific patients, yes. Postpyloric feeding has been shown to reduce aspiration risk and often allows you to reach goal feeding rates faster because you're bypassing a potentially dysfunctional stomach. Placement can be trickier, sometimes needing endoscopy or fluoroscopy.
Got it. Now, let's talk about something that's been a huge practice change. Gastric residual volumes, or GRVs, checking how much is left in the stomach.
Yes. This is probably one of the most significant shifts in critical care nutrition practice in recent years. The consensus guideline is now clear. Routine measurement of GRVs is not recommended for most patients getting gastric feeds.
That's a big departure. Nurses often see GRV checks as a key safety measure against aspiration. Why the change?
It generated a lot of discussion, for sure. But the evidence from multiple randomized trials was compelling. Routinely checking GRVs and holding feeds for arbitrary volumes, sometimes as low as 150 or 200 milliliters in older protocols, did not actually reduce the risk of ventilator-associated pneumonia or other complications.
Really? No difference in VAP?
No significant difference. What eliminating routine checks did do was dramatically reduce the number of times feeds were unnecessarily stopped. Those interruptions were a major reason patients weren't getting the calories they needed. We were prioritizing a practice with no proven benefit over actual nutritional delivery.
So the focus shifts to clinical signs of intolerance.
Exactly. Look for vomiting, abdominal distension, patient complaints of discomfort or pain. Rely on head of bed elevation. That's where the focus should be, not on an arbitrary volume in the stomach.
But what if a hospital does still check GRVs, or there's a specific clinical reason? Is there a threshold now?
Yes. If GRVs are measured, the guidelines recommend not holding feeds unless the volume is greater than 500 milliliters. And even then, you should consider it in context with other clinical signs, not just hold automatically based on the number alone.
500. That's much higher than the old cutoffs.
Much higher. It reflects the lack of evidence linking lower volumes to adverse events.
Okay. Let's shift to what we're actually putting in the tube. Formula selection. Is there a default?
Absolutely. Yeah. And the message here needs to be simple and consistent. For the vast majority of hospitalized adults who tolerate EN, the first-line choice should be a standard polymeric formula,
Polymeric meaning?
meaning it contains intact nutrients, whole proteins, complex carbohydrates, standard fats. These are generally well-tolerated, nutritionally complete, and the most cost-effective option.
But there are so many other formulas out there. Elemental, semi-elemental. When are those needed?
Those contain nutrients that are already partially or fully broken down, like hydrolyzed proteins or peptides, medium-chain triglycerides. They are really reserved for specific, pretty severe malabsorptive conditions.
Like short bowel syndrome.
Exactly. Short gut, maybe some cases of severe pancreatitis, refractory Crohn's disease, certain types of fistulas, situations where the gut truly cannot handle or absorb intact nutrients. Using them routinely for general critical illness or recovery is not evidence-based and adds significant cost.
What about all the disease-specific ones? Formulas for diabetes, kidney disease, lung disease.
The guidelines from ACG and ASPEN generally advise against the routine use of most disease-specific formulas.
Even the diabetic formulas, they seem logical.
While they might have altered carbohydrate profiles, studies haven't consistently shown that they lead to better clinical outcomes like improved mortality, shorter length of stay, fewer complications compared to standard formulas when blood sugar is appropriately managed with insulin. Managing the insulin is usually more effective and cheaper than changing the formula. Same logic applies to renal or pulmonary formulas, limited evidence of real clinical benefit for routine use.
Is there any specialized formula with a strong recommendation?
There is one specific and quite narrow indication: immune modulating formulas, or IMS.
What's in those?
They're enriched with specific nutrients thought to modulate the immune response, like arginine, glutamine, omega-3 fatty acids.
And where are they recommended?
The recommendation is very targeted. They're only recommended for patients undergoing major elective surgery who are being cared for in a surgical ICU. In that specific perioperative setting, some studies suggest IMFs can reduce infectious complications and shorten length of stay.
Only surgical ICU after major surgery, not medical ICU.
Correct. Critically, the evidence does not support their use in general medical ICU patients, especially those with sepsis. In fact, there's concern that the high arginine load in some IMS could potentially be harmful in septic patients with uncontrolled inflammation. So outside of that specific surgical ICU context, stick with standard polymeric formulas.
That's a really important distinction. Stick to standard unless it's that specific surgical ICU case or severe malabsorption.
That's the takeaway. Keep it simple, keep it standard, unless there's a compelling evidence-based reason to change.
Okay, so we've started the feeds, chosen the formula. What are we aiming for? What are the targets?
For energy, the general target for most stable hospitalized adults, and once critically ill patients are past that initial acute phase, is usually around 25 to 30 kilocalories per kilogram of actual body weight per day.
Standard target. But protein is different now.
Protein is where the emphasis has really shifted. Because illness drives such high catabolism and impairs protein synthesis, we need to be much more aggressive with protein delivery.
How aggressive?
The target for critically ill adults is now 1.2 to 2.0 grams of protein per kilogram of actual body weight per day. That's significantly higher than older recommendations.
1.2 to 2.0 grams per kilo. Wow. What about obese patients?
For patients with obesity, usually defined as a BMI over 30, the protein target might be even higher, potentially up to 2.0 or even 2.5 grams per kilogram, but calculated based on their ideal body weight, not their actual weight, to avoid overfeeding calories.
Okay, this brings up that protein paradox again. If we're starting feeds restrictively in the first few days of critical illness, keeping calories low like 15 kilocalgen, how on earth do we get 1.5 or 2.0 grams calorie of protein in? Standard formulas don't usually have that much protein relative to calories.
That is the million-dollar question right now. It's a real practical challenge. Standard formulas might have a protein-to-calorie ratio that makes it impossible to hit that high protein target while staying within the restricted energy goal.
So what's the solution?
It requires a deliberate strategy. One option is to use higher protein, lower calorie density formulas if available. But more commonly, the approach involves using modular protein supplements.
Like protein powder.
Exactly. Adding protein powder or liquid protein concentrates directly to the enteral formula bag, or administering them separately through the tube as a flush or bolus. This boosts the protein delivery significantly without adding a huge caloric load.
That sounds like it needs careful planning and protocols.
Absolutely. This needs to be built into feeding protocols and likely requires close collaboration with dietitians. You have to calculate the protein deficit from the base formula and figure out how much modular protein is needed to bridge that gap while respecting the energy restriction. It's not straightforward, but it's crucial for hitting those modern protein targets.
Is there a risk of too much protein?
Yes, we need to be a bit cautious, especially with very high doses, say over 2.0 kg day, particularly in the most unstable phase of illness or if the patient has significant acute kidney injury, AKI. The nitrogen load from protein metabolism can increase BUN and potentially worsen azotemia or metabolic acidosis in some settings. So monitor renal function closely if pushing high protein doses.
Okay, monitoring. What else needs close watching?
Beyond the basics intake output, daily weights or at least weekly, watching for tolerance. The most critical daily lab monitoring, especially when initiating feeds, revolves around electrolytes, specifically potassium, magnesium, and phosphorus. These need to be checked daily for at least the first 5 days after starting EN, maybe longer in high-risk patients.
Why those three in particular?
Because they are the key players in refeeding syndrome, RFS.
Ah, RFS. That's the potentially lethal complication when you restart nutrition in someone who's been starved or severely malnourished.
Exactly. When you reintroduce carbohydrates predominantly, insulin levels rise, driving glucose into cells. But phosphate, potassium, and magnesium get pulled into the cells along with it, needed for metabolism. This can cause rapid, severe drops in the serum levels of these electrolytes.
And those drops cause?
Hypophosphatemia is the hallmark, and it can cause profound muscle weakness, including respiratory muscle failure, cardiac dysfunction, arrhythmias, confusion, seizures, rhabdomyolysis. Hypokalemia and hypomagnesemia also contribute to arrhythmias and weakness. It can be fatal if not anticipated and managed.
So we need to know who's at high risk before we even start feeding.
Definitely. Classic risk factors include very low body weight, BMI 18.5, significant recent weight loss, like over 10-15% in the last few months, prolonged periods of little to no nutritional intake, say 7-10 days, chronic alcoholism, oncology patients undergoing chemo, anyone severely depleted.
And how do we prevent it in those high-risk folks?
Prevention is key. It starts with recognizing the risk. Then you initiate feeds very slowly and cautiously, maybe starting at only 25-50% of goal calories, or even just 10 kilocal days, sometimes capped at 500 kilocal day initially.
So even more restrictive than the standard critical care start?
Potentially, yes, for the highest risk patients. And you advance the rate very gradually, maybe over 4 to 7 days, to reach the goal.
And electrolytes.
Monitor K, MIDMG, face theory before starting and during the advancement. Replete any baseline deficiencies before you start feeding. And critically, thiamine.
Thiamine, vitamin B1. Why is it so important?
Thiamine is a crucial cofactor in carbohydrate metabolism. When you certainly provide carbs to a thiamine-deficient patient, common in alcoholism and malnutrition, you can precipitate acute thiamine deficiency, leading to Wernicke's encephalopathy or cardiovascular collapse. Wet bearberry.
So everyone at high risk for RFS needs thiamine?
Absolutely. The recommendation is aggressive thiamine supplementation, usually 100 milligrams daily, often given IV or IM initially to ensure absorption, for at least 7 to 10 days when starting nutrition in anyone at high risk for RFS. Give the first dose before or concurrently with starting the feed.
Okay, so start slow, advance gradually, monitor electrolytes daily, replete aggressively, and give thiamine. What if, despite that, the labs start dropping?
You have to react immediately. If phosphate, potassium, or magnesium levels drop significantly, say, below the normal range, or even a drop of 30% from the previous day, even if still in the low normal range, that's a major red flag.
What do you do?
You need to immediately reduce the rate of the enteral nutrition, often by 50%, or even holding it temporarily. You initiate aggressive IV repletion of the deficient electrolytes based on protocols. And you do not advance the feeding rate again until the electrolytes are stable and adequately replaced. You basically have to halt the refeeding process until the cellular machinery is caught up.
Constant vigilance is key there.
It really is. RFS is preventable and manageable, but only if you anticipate it and monitor closely.
Okay, let's touch on managing more common GI side effects. Nausea, vomiting.
Often related to delayed gastric emptying. First step is usually trying a prokinetic agent. If that doesn't work or symptoms are severe, that's a strong reason to consider switching to postpyloric feeding access.
And diarrhea. Everyone blames the tube feeds first.
They do, but it's often not the formula itself. Diarrhea in tube-fed patients is frequently multifactorial. Before you jump to changing the formula, you have to do some detective work.
Like what?
Review the medication list carefully. Are they getting liquid meds containing sorbitol, which is an osmotic laxative? Are they on magnesium-containing antacids? Are they on multiple antibiotics disrupting their gut flora?
Could it be infectious?
Absolutely.
Uh-huh.
Always consider C. difficile, especially if the diarrhea is new onset in a hospitalized patient, potentially after antibiotics. Test for C. diff toxin. Only after ruling out medications and infection should you consider manipulating the formula, perhaps trying one with fiber, or malabsorption is suspected, maybe a semi-elemental trial, but that's further down the list.
Good points. Don't just blame the formula. And aspiration pneumonia, the big fear.
Primarily mitigated by keeping the head of the bed elevated, using prokinetics if needed. Postpyloric feeding is the fallback for those highest-risk patients or those who fail gastric feeding despite other measures.
Okay, this has been a really comprehensive look. Let's try to synthesize the key takeaways, the big picture for managing EN now.
I think the major themes are early initiation, definitely within 24 to 48 hours for high-risk patients, especially in the ICU.
But paired with that restrictive energy dosing in the acute phase of critical illness, don't push calories too hard, too soon.
Right. Then the emphasis on high-protein delivery, aiming for that 1.2 to 2.0 decilkilogram target, often requiring modular protein supplementation.
Formula choice. Standard polymeric first line for almost everyone. Reserve specialized formulas for very specific narrow indications, severe malabsorption, or IMF only in the surgical ICU post-op setting.
Operationally, the move away from routine GRV checks is huge. Focus on clinical signs, and if you do check, the threshold is 500 milliliter.
And rigorous RFS prevention. Identify high-risk patients, start slow, give prophylactic thiamine, and monitor K, Mg, FALS daily, reacting quickly to drops.
It's clear that getting this right isn't just one person's job. It really demands a collaborative, multidisciplinary approach. Physicians, dietitians, nurses, pharmacists, sometimes GI specialists. Everyone needs to be on the same page with these evidence-based protocols.
Absolutely. Which brings us to a final thought, perhaps a challenge for listeners to consider in their own practice. We've talked about the strong evidence for restrictive energy feeding early in critical illness, maybe only 15 to 20 kilocalogram. But we also need high protein, 1.5, 2.0 gigacalags. How do we practically, systematically ensure we achieve that high protein target at the bedside when the energy goal is deliberately kept low? How can we best leverage our EHRs, our order sets, our nursing protocols to make meeting that high protein goal the default even during energy restriction?
That's the real implementation challenge, isn't it? Moving from knowing the targets to reliably hitting them for every patient, it likely requires smart system design.